So this is a structured Viva task assessing communication with patients, communication with colleagues, patient safety, and applied clinical knowledge. You are doing a routine hysterectomy for multiple fibroids. Your consultant is attending a meeting at this time, and you have suspected that you damaged the left ureter at the level of pelvic brim. The examiner will discuss with you regarding the management of this complication. So again, this is another intraoperative complication. If you didn't listen to the video of bowel injury, you should go first for that video and then come back here, because the first question, what will be your immediate action, will be the same, exactly the same. So I will repeat it again quickly, but if you want it in detail, you can go and listen to that the previous video. So here we will not stop the procedure, we can continue our procedure. However, at the same time, we need to communicate with everyone. So I'll communicate with the anesthetist, I will communicate with the scrub nurse and also the circulating nurse. So here I need to ask the circulating nurse to call my consultant and also to call the on-call urologic consultant, okay? So what are the common sites of ureteric injury during hysterectomy? So we have very specific sites which are very common when we dissect the IP ligament, the infundibulopelvic ligament, at the pelvic brim. That's very common site of injury because the ureter is very, very close to the IP ligament, okay? Then another site which is in the ovarian fossa, so it lies behind the ovary while we are taking the ovary out, so it can be injured there. And the site which is lateral to the cervix while we are doing division of the uterine artery or ligation of the uterine artery. So that's why when we before we ligate the uterine artery, we need to properly skelenotize it and dissect the bladder downward further to take the ureter down, okay? At the pelvic brim, while we are doing a ligation of IP ligament to remove the ovaries, we need to clearly visualize the ureter course before we apply the ligation, okay? Because sometimes it may be like, you know, very, very close. Sometimes it's away from us, but we need to be visualize it really before we do that, okay? So these are the common sites. So ureteric injury can be of several degrees. It's either just laceration or hematoma, and laceration can extend to the 50% to the external wall, and again laceration which may extend to more than 50%, or complete transection, or avulsion. Avulsion means it is taken off from the kidney or from the pelvic kidney, from the kidney, the pelvis, the renal pelvis, I mean. So that's different grades. So usually we deal when we are causing ureteric injury, it may be either laceration or transection. We will not do avulsion, okay? um, so once our consultant come and the urology consultant come, what they are going to do? So they need to confirm and identify the ureteric injury. So how we confirm that we have a ureteric injury in the field? First, how we suspect? We can suspect that when we suddenly found fluid coming in the field while we are dissecting, and it can be either bladder injury or ureteric injury. If you see fluid which is like, you know, sometimes the smell of urine will come out and you can smell it. Okay, so fluid coming in the field, and you suspect that while you are doing the operation. So if you are dissecting the bladder and suddenly the fluid comes, you will suspect a bladder injury. But if you are doing IP ligament, for example, you will suspect ureteric injury. Okay, so how they will confirm? So they have to do what we call the meticulous dissection, like very fine dissection till they identify the injury. Uh, to see the peristalsis of the ureter does not exclude the injury, so don't be reassured if you see the peristalsis that you didn't hit the ureter. No, it can be injured and peristalsis may be still there. Okay, so if with meticulous dissection there is no clear injury identified, what we need to do, we can give the patient IV dye, okay, like methylene blue. And if we found the extravasation of the dye in the field, there is injury. So it can be either also bladder injury or ureteric injury. So how we will diagnose where is the site of the injury? So the urologist has to do a cystoscopy and see whether this dye is coming through the ureteric orifices or no. He has to see the dye ejecting from the orifices. That means the bladder is injured. If it is not ejecting from the orifice and coming in the field, that means ureteric injury. Okay, so how we will repair the ureteric injury? So it depends where is the injury happens. So we have two methods. So if the injury is high up, like the first photo on the left, uh, and it's away from the bladder, we can do what we call uretrostomy. We will connect the ureter to the other ureter. Okay? If it is lower down in the lower half, so it can be re-implanted into the urinary bladder. So we'll take a flap from the bladder and, like, you know, surround the injury site and do suturing like a flap, and that's as you can see here. So that is we call it uretrocystostomy, uretrocystostomy, or ureteric implantation into the bladder. So it depends where is the injury. If it is in the upper half, we can do ureterostomy or end-to-end anastomosis. Sometimes we can connect the two parts and we call it end-to-end anastomosis. Or if it is lower down, we will implant it into the bladder. So the suture should be with fine absorbable suture like 3O polygalactine or Vicryl, and should be watertight. What is the meaning of watertight? That means that we need our sutures not passing urine even under pressure. Like if you fill this to maximum and you put pressure, it should not pass any water. So for that reason, we need to take it in a continuous manner, not like the bowel injury. The bowel injury is taken interrupted and tension free. This also will be tension free anastomosis. However, it should be continuous suturing and watertight suture. Okay? For sure, as I told you, any injury we need to give antibiotics, we need to put a drain. So both of them we will be uh, like in bowel injury and ureteric injury, we need to put drain. But you know, because the ureter is very delicate structure and we have sutured it, and it can, you know, it can open again and will be liable for infection and UTI. What we need to do? we need to put what we call double J stent. So that's the double J stent. What is the meaning of double J? Double J means a curved ends. So if you see number 1 is a curve and number 3 is another curve, so the ends are curved. We call it double J, like it resembles the letter J on either sides. And the tube itself, which is number 2, the tube itself is a hollow tube which drains the urine and keep the ureter intact outside to allow healing of the sutures. Okay, so this plastic tube, it's hollow plastic tube, is the one which is going to do the job of the ureter and continue to drain the urine till the defect is completely healed. Okay, and this stent can be left for a month or 6 weeks so that we will give enough time for the healing, and the drain should be left for at least 48 hours. Why? Just to be sure there is no leaking of urine inside the peritoneal cavity. Okay, and after we do that, we need to again give IV dye, IV methylene blue, and see if there is any extravasation happen, just to be sure that we did it properly and there is no leakage of the dye. Okay, so the post-operative measures. As I told you, we will keep the stent for 4 to 6 weeks. We will keep the drain for 48 hours. We need to put a bladder catheter, Foley catheter, and we need to keep it at least for a week. Okay, and the antibiotics IV should be continued for 24 hours for any suspected injury, bowel injury, bladder injury, ureteric injury. We need to give IV antibiotics for at least 24 hours, can be extended to 48 hours if the patient showed any signs of infection, then to be converted to oral. The aim of antibiotic here, because we are going to put a catheter, we put already a stent, and that's why we need to prevent UTI from happening. Okay, so this stent should be removed when? After 6 weeks. Okay, so how it will be removed? So sometimes they put a thread on the lower end here at number 3, and the threads, like like the threads of the coil, the IUD, and these threads can come out from the urethra. Okay, so when it is due for removal, they will just pull the thread and take the stent out. Okay, sometimes these threads may not be available, like the stent with the threads may not be available. So for removal, we can do a cystoscopy and take it out. Okay, so after 6 months, we need to do IVU again, just to be sure that it is healed completely and no problems at all. So we'll put another dye intravenous and see ureteric patency and no leak of the dye. Okay, just for reassurance. Again, what we are going to do, we will leave the drain, we'll keep the IV antibiotics for 24 hours. We will put an incident report, we will document, debrief the patient, do the duty of condor, reflect on our e-portfolio as a reflective practice, and also we need to know our limitations, select the patients, everything as we did in the bowel injury station. Okay, so that's all for ureteric injury. It's very common actually in hysterectomy, so we need to be careful while we are doing, and we need to identify the course of the ureter before we ligate the IP ligament. Before also we are doing the uterine artery ligation, we need to properly dissect the bladder and keep it further down so that it will take both ureters together downward. Okay, thank you.